Good afternoon and good evening to all the delegates, students, consultants in the field of hematology who have logged in not only from India but across the world. Why we said morning, afternoon, and evening? Because this is the most sought after academic series in the field of hematology running since the COVID time. That's more than 6 years. I am Ashish Shah from Intas Pharmaceuticals Limited, and it is our pleasure to welcome each and everyone in today's academic feast under the aegis of Mumbai Hematology Group and, supported by Intas Pharmaceuticals Limited. Very interesting thing which we have noticed in the past 2 months, which we all know that world came to a standstill, uh, a majority of the part of the world due to the West Asia crisis. The world came to a halt, but not the academic initiatives of Professor Dr. M.B. Agarwal, sir. We are extremely grateful to you, sir, for ensuring that every student, every consultant remains updated about hematology every weekend. Thank you so much, sir, for uh, updating us with the latest advances on behalf of everyone. Now, without wasting much of the time, we now request sir to take the proceedings forward.
So, good evening to friends from India. Today we have two speakers, Dr. Neeta Radhakrishnan from Noida and Dr. Ranjana Advani from California. Our first speaker is Dr. Neeta. She will be speaking to us on managing inherited bone marrow failure syndromes. As you are aware, these webinars are brought to you by Mumbai Hematology Group, and this is supported by INTAS, managed by Perfect Square. I thank Dr. Manoj Kumar, Mr. Arun Hegde, Mr. Anis and their team from INTAS, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speakers, Dr. Neeta and Dr. Ranjana, all our discussants who are themselves eminent clinical hematologists, medical oncologists, hematopathologists, and pediatric hematologist oncologist. And of course, you participants for sparing your Thursday evening. Next Thursday, 14th of May at 6:30 p.m., you Dr. Mona Vijayaran from STPGI Lucknow speaking to us at 6:30 p.m. on inborn errors of immunity in hematology, interplay and recent advances. And this will be followed by Dr. Jardine Fabrice from France, and he'll be speaking at 7:30 p.m. IST on ctDNA and lymphomas. Introducing Dr. Neeta Radhakrishnan to all of you. You all know her. She has been our speaker and faculty at a number of occasions in the last 6 years. She's additional professor and HOD, Department of Pediatric Hematology Oncology at Postgraduate Institute of Child Health, Noida, UP. She's a leading pediatric hematologist oncologist in India with 25 years plus of clinical and academic experience. She's widely recognized for her leadership in improving childhood cancer care and hematological outcomes both nationally and internationally. Chair of the IPA Working Group on Childhood Cancer, Executive Board Member of CEOP Asia, Honorary Secretary of the IIP PHO Chapter, holds an MBBS from Trivandrum Medical College, MD in Pediatrics and FNB in Pediatric Hematology Oncology from Sir Gangaram Hospital, Delhi. She was named Precision Hemato-Oncologist of the Year 2025 as she recipient of the CEOP My Child Matters grant. And today, as was mentioned, she'll be speaking to us on managing inherited bone marrow failure syndromes. Thank you. I'll stop sharing and hand over the platform to her.
Good evening, everybody. I would like to thank Dr. M.B. Agarwal sir and the Mumbai Hematology Group for this opportunity. I hope my audio and video is clear.
Perfect.
Slides are clear.
Perfect.
Thank you. So in the next 45 minutes or so, we'll be discussing management of inherited bone marrow failure syndromes. And me being a pediatrician, my focus would be on diseases which are diagnosed in pediatric age group and how do we get them to a treatment as in transplant as well as non-transplant management. So inherited marrow failure syndromes, as you all know, these are conditions which would have not just bone marrow failure or MDS as part of their presentation. It could be children presenting to us, so patients presenting to us with malignancies, and these are generally hematological malignancies, and at times cancer predisposition syndromes can be, it can also predispose to solid organ tumors as well. With the advent of NGS, we diagnose more and more. So earlier, probably if a chromosomal breakage study or a telomere, if we have telomere length testing available, it would stop at that. But with now and NGS available, more than 100 disorders have been identified in this group. And again, there are many new diseases which are coming up, and we actually read about the condition after we hear it from the report, which the NGS report that comes to us. So this is classical teaching. When should we suspect IBFMS? Hematological clues. I think the biggest screening tool or the best way to pick it up in a routine BC OPD is MCV. For all the students who are joined in, it's MCV with any cytopenia or MCV even without any cytopenia. If high MCV is there, it's always sinister. And when we are, as in pediatrics and in hematology, we initially taught that high MCV is megaloblastic anemia. And so it is in our population, definitely around 20 to 30% of children who present to us will have megaloblastic anemia or megaloblastosis in some form. It may not be anemia as such or combined nutritional anemia. But if a patient is coming to you with any kind of cytopenia, any infection, any presentation, if that MCV is high and if you do not have a peripheral smear correlate like a hypersegmented neutrophil, often you'll have to keep a watch. If it's severe cytopenia, you do a marrow immediately. If it's an infection admission with mild cytopenia, maybe you watch, but keep the child under your follow-up because this is something which can be sinister. All aplastic anemias, all MDS would require evaluation for inherited marrow failure syndromes. And now patients who even have monocytopenia, so it's no longer neutropenia, just neutropenia or thrombocytopenia. It could be monocytopenia as well, which can lead to conditions which can come under the IBFMS bracket. Early onset MDS definitely, like I said, and all monosomy 7 AMLs also should undergo evaluation for IBFMS, especially GATA2. Now, again, classical congenital features, I think all of us know. The most common ones are short stature, capsular macule, failure to thrive, thumb and radial ray defects, etc. For the classical FA or Fanconi phenotype. Nail dystrophy, reticular pigmentation in DKC, capsular, it can be generalized hyperpigmentation or it could be capsular macules. It could be one large capsule or it could be multiple small, which keep increasing. Any craniofacial anomaly with anemia or any cytopenia, suspect this. Renal anomalies, cardiac anomalies, often that is the pickup point for us. And many a times these are conditions which may actually make the patient not fit for a bone marrow transplant. If you have a single kidney which is going in for renal failure or Eisenmenger syndrome, etc., it might be difficult to do a transplant along with that. What we should remember is 20 to 40% of FA and many of the marrow failure syndromes at large, like for example, a congenital megakaryocytic thrombocytopenia or a severe congenital neutropenia, etc., will not have any phenotypic features. So because of this, so just because there is a cytopenia, if you're picking up a cytopenia, definitely go ahead and evaluate further. And a lot of work in India has been done by Dr. Babu Rao's team, especially for Fanconi. So when in doubt, do reach out because their team is very helpful with the samples. Even so, if you have a VUS pick come up, you have a clinical correlate, but then your report is showing only a VUS or a report is showing only a heterozygous mutation. There have been multiple instances like that for us where he actually has sequenced it again and we have a final diagnosis of FA per se. So these are classical images, which I think are there in all textbooks. Witness nothing very specific. It's a spotter child with a triangular facies, craniofacial anomalies, limb anomalies, etc. like this. And this is nail pitting that you can see in a girl with DKC. Now, it is no longer only hematological and phenotypic features as such. It could be infections as well. So many of these conditions will have other immune deficiencies which are not neutropenia related, which could be severe bacterial fungal infections, viral warts, HPV disease in patients with GATA2 deficiency, non-tuberculous mycobacterial infections, and the ones which keep recurring again. So patients come to you, infection as treated as tuberculosis, 1 year, 2 years later, again tuberculosis. So that kind of a presentation also, keep a watch out for something more than just a community acquired infection. Organ dysfunction. So the classical one is in severe congenital neutropenia patients. As in neutropenia patients, you could have pancreatic insufficiency. Again, in small babies, it may be difficult to diagnose, and many a times it is pancreatic insufficiency often is not obvious in the initial few years as well. So that can be difficult to pick up. Telomere biology disorders, pulmonary fibrosis in later years, restrictive lung disease, again, becomes difficult to transplant after a point of time because of the lung condition per se. Liver fibrosis, cirrhosis. So people who have the milder phenotype of the telomere biology spectrum, people who have autosomal dominant presentation, etc., may just come with only organ involvement and may not have any hematological manifestations also. So again, from Professor Neil Young's talks, that if you have early graying in the family, if you have liver cirrhosis, if you have alcoholic patients who have been labeled as alcoholic disease or alcoholic liver disease or lung fibrosis, etc., and having somebody else in the family with a cytopenia, definitely evaluate for telomere disorders. Unexplained cytopenias in any relative. For example, there will be conditions where the mother would be mildly thrombocytopenic, never picked up, and it turns out to be DKC later. So this is the classical ways of presentation, and you can see these are pictures from a child with severe congenital neutropenia, Elaine mutation with punched out palatal ulcer and oral thrush. You can see that so fungal infection gone really bad, and these classical ulcers which you get in neutropenic patients. Now I've picked up few cases which were not so classical. So this is a 14-year-old boy who is presented with anemia, 2 months of duration, comes in with a hemoglobin of 6, MCV of 102, a normal WBC platelet count. So nothing really to suspect marrow failure at that point of time. Macrocytic cells, and here you can see they were actually hypersegmented neutrophils as well. Started on B12. So hemoglobin 6, otherwise stable, send him home. Always when you send home B12, any high MCV anemia, so if you're sending home, always call back early because this could be something more than just nutritional. So we did not see a response by day 3, day 4. So then went ahead, did a marrow, and it turned out to be AML M7. There was a monosomy 7 associated AML. Now the thing is, of course, it required a transplant. This was the only child. So mother gave an interesting history that all her previous children had died. And so there was no other sibling, and only haplotransplant was the option. Counseled, parents were not willing. So just gave chemotherapy and completed treatment. Interestingly, throughout the treatment, the child did not have any issues, tolerated all the 3+7s and the HiDACs well without any difficulty as well. After treatment, almost a year after completion, after a few months after completion, the next 1 year, now this is the time when he starts coming in with infections, progressive lymphopenia. So this lymphopenia was also very surprising because why would a patient with myeloid leukemia have lymphopenia now? So there is not platelets are normal, everything is fine. Just the lymphocyte count would come down to like initially 600, 800, then 300. And then, and with that lymphopenia came in infections as well. Recurrent episodes of diarrhea. Couple of times he had crypto, and in such a big child, hypokalemic periodic paralysis also. And interestingly, this is the time when these kind of small lesions would come up on his forehead, and this used to shed off and it would come back again. So we never knew what it was at that point of time. And then all this treatment was going on. Lymphopenia, lymphocyte subset were done. All three, CD3, 4, 8, all of were low. And they like, okay, let us rule out something else. Maybe this is some kind of late skid manifestation or whatever. And it turned out to be GATA2. And this was one of those frame shift mutations, which was very significant pathogenic mutations. And this child, by the time we had this diagnosis and we were counseling, he came in with a bad bronchopneumonia and he died after that. Another child with, again, another leukemia, which is ALL. Standard risk ALL, CNS 3 presentation, good prednisolone response. Initially, when everything goes very well, but then the profile of infections, if you look at from the disease perspective, it was all fine, but infectious profile was completely unexpected. So it was sepsis, multiple deep abscesses, bilateral pneumothorax, I think 4 or 5 times ICD was put for him. 5 episodes of meningitis during this ALL treatment, recurrent paraplegia with a cervical abscess. And then there was no way to get the tissue report out of it or a microbiological report from that. He would respond to voriconazole. And so in this kind of infectious profile, again, he required transplant. He required radiation. We had no guts to do radiation for such a patient. So we just kept him on maintenance until he had a CNS relapse, after which the family opted not to treat. So this turned out to be another similar condition, similar to GATA2, which has been recently, as in a couple of years, it has been described on called SAMD9L mutation, which presented. So he did not have the typical ataxia presentation, but it presented with leukemia. A lot of patients present with myeloid leukemia as the predominant feature, but ALL also has been described. Very common pediatric presentation is the so-called nutritional anemias. Here again, MCV becomes very important. Cytopenias, child presenting with diarrhea, very common viral infections, lot of conditions present with like this. So marrow was done by pediatrics. They added B12 folate, discharged her home, came back with similar cytopenias, high MCV, did a marrow, turned out to be Schwammen diamond. So this MCV being high, always ask the pathologist to look for underlying B12 folate. If it's not there, do a marrow, definitely B12 folate presentation in the peripheral smear, or even the levels as well. Or you try supplementing and decide on a marrow quickly. Any anemia with an anomaly. So this is a boy, a recent patient for him, who came in with this kind of lymphedema, which is there from birth. Family is not very worried about it. And antenatally, he had some hydronephrosis also, which also he's under follow-up from a nephrologist for the same. So renal function is absolutely normal, but 5 months of age, since 5 months of age, he has progressively increasing pallor and hemoglobin 5, platelets, neutrophils so far okay, MCV is 90. And here, I thought, because it was lymphedema with the earlier patient in mind, I thought it was GATA2. We thought maybe it should be PRC also, high MCV anemia and thus typical age presentation requiring transfusion. They had a marrow report from outside which said 6% blast, but when we did we repeated it, there were no increase in blast, marrow was hypocellular, and of course the diagnosis was picked up on whole exome as MDM4 mutation. This is a novel marrow failure. Again, like I said, lot of conditions where we actually go back from the diagnosis to learn about what is the condition about. So it is a condition which where there is a disruption in this MDM4, which is it's a negative regulator of TP53. And when there is this disruption, it has implications with hematopoiesis. And there are very few patients reported with pancytopenia or just a red cell aplasia like in our patient, neutropenia, megakaryocytic dysplasia. Siblings with macrocytosis, again, a new learning. 2 children, as in the first one is brought with anemia, with MCV high, again high, the same reticulocytes just 0.3%. They did a marrow thinking this is PRC. So he's an older kid, no phenotypic features at all. So this kid is around 8 years when he comes to us and picked up as GATA1. So GATA1 is an X-linked disorder, and both GATA1 and GATA2 play a crucial role in hematopoiesis. And here, this was GATA1 mutation. So GATA1 mutation. So the GATA2 is expressed in the hematopoietic stem cells and the early erythroid precursors, where it activates genes which are essential for early progenitor function. And then it initiates GATA1 gene expression. So once the GATA1 gene expression is activated, it facilitates the expression of genes associated with the erythroid differentiation. So now this switching from GATA2 to GATA1 is crucial. And when you have GATA2 insufficiency, haploinsufficiency, like we saw in the earlier patient, that leads to conditions like AML and MDS, whereas mutations in GATA1 are linked to erythroid issues, basically dyserythropoiesis and thrombocytosis, as in thrombocytopenia group of disorders, platelet group of disorders. And this is how it is. The more severe ones are very lethal, and the ones which are lesser, they're like probably in our patient, present with anemia and thrombocytopenia. For us, it was just anemia. And the interesting thing is, one kid comes in, so we gave a trial of steroids, it worked for him, and hemoglobin is maintained around 10, very low dose steroids, probably around 2.5 mg weekly, that kind of a dose. And we counsel them that, okay, we'll just keep you on this thing. Nothing is required as of now. The other sibling, is he okay? He's healthy. 2 years later, after the first diagnosis, the other child is again brought, again around 6, 8, 7 years of age, with similar complaints, exact same disease, which is picked up in the sibling as well. Both healthy, otherwise growing well, children without any phenotypic features whatsoever. Many thrombocytopenias that we encounter, we have as a knee-jerk reflex to label it as immune thrombocytopenia. But if your marrow shows MEGs which are low, MEGs which are dysplastic, or MEGs which are hypogranular, please look out for other conditions like congenital megakaryocytic thrombocytopenia, which can be very, very severe and will not respond unless you transplant them early in life. And these are children who had intracranial bleed at the time of presentation. So this is the classical teaching of Fanconi, DKC, DBA, Schwammen, Diamond, etc., who presents with MDS, presents with cytopenia, goes on to MDS, and then myeloid leukemia. Whereas now you have a whole big spectrum which explains the mechanistics behind marrow failure. It's not only DNA damage response, which is the FA phenotype, telomere biology, which is a DKC phenotype. Now, ribosome biogenesis, which is Schwammen Diamond as well as Diamond Blackfan anemia, a whole new group of disorders which interfere with the transcriptional regulation, or the HSC niche dysregulation has been described, or it is ongoing. It's every year there are new diagnoses which are coming in, which interfere with the stem cell renewal as well, and that results in cytopenia. So it's now a more of genotype based diagnosis, and to decision to do based on what the genotype is, rather than how we were managing these children earlier. Chromosomal breakage studies are still important in the diagnostic algorithm, but one must remember that for many patients, chromosomal breakage may be falsely negative. In patients, especially the ones who have hematopoietic reversion, delayed diagnosis can occur because of that. These children, because they are mosaics, they have cytopenias which would be normal, or cytopenias which would improve in due course, but their risk of MDS and AML remain. So genetic or molecular testing, which is not so difficult in our country, is very, very important, not just to establish a diagnosis, prenatal and all those things, but also to prognosticate, to know what their cancer predisposition will be. And there are implications for carrier screening in some of these mutations as well. So for the parents also, and as well for other siblings. The whole the group of telomere biology disorders, it was difficult to diagnose earlier as well. It continues to be difficult because there are so many diagnoses now. So you don't know what exactly to do with each of these disorders. And the younger ones, the ones which are going to present in infancy, they are the ones which are going to present with many other manifestations other than cytopenia per se. So it could be like children who come with patients with cerebral calcification. So a lot of them actually matches a torch phenotype, a childhood who would come in with a congenital CMV or toxoplasma, etc. So many of them would not even will have a hematology referral at all. I have had patients who are, had liver failure in neonatal period, and NGS later after the death of the child got picked up as DKC. So these are conditions where no cytopenia at all in that initial period. And then we have a diagnosis later after, probably in this patient, which was postmortem. The typical DKC presentation would be at around 8 to 10 years of age. And then the older phenotype, the older patients who present, the ones which have autosomal dominant or the milder disorder, so to speak, which would come with an organ involvement, like we discussed earlier, the liver involvement or the early graying, etc., that would present, or even in elderly age group, it would be idiopathic pulmonary fibrosis or interstitial pneumonia, that kind of presentation as well. Now here, there are genetic mutations which affect telomere repair as well as telomere maintenance. Both of them result in attrition. So I'm not going into details because we have a lot of things to cover today. But essentially screening was and screening is it's ideally through telomere length measurement. So it's either through a PCR-based technique or a flow fish, and less than first centile for age, for that particular age, is both sensitive and specific for this condition. But it is extremely difficult to get it done practically to get it done. So there are few centers in our country we are doing it. When a sample is shipped with the control, we do get a report. The only thing is, many a times patients, a lot of heterozygous states will have telomere length between 1 to 10 centile. Point number one. Point number two, it can happen in other marrow failure syndromes as well. And point number three, many a times it could be there in aplastic anemia patients. Idiopathic aplastic anemia patients also may have reduced telomere length. So at times, with a diagnosis, with a mutation report with you as well, it becomes difficult to get to a final decision making. It requires a lot of discussions, collaborations with expert to decide what to do for your patients. So these are the tests which are available. And this is the algorithm, which is a proposed algorithm for getting to a diagnosis. If it's less than first centile, it's likely to be telomere disease. If it is between 1 to 10, it is possible. And screening and genetic testing, etc., is recommended at that point. And if it's more than 10 centile, of course, telomere length is unlikely in this thing. And these are the suggested phenotypic features, which we already saw. So coming after this, then it comes to the genetic disorder, definitely, the genetic diagnosis, definitely. Molecular diagnosis is imperative. It is something which we cannot wish away, and screening is no longer enough for our patients. And molecular genetics, molecular diagnosis, when you encounter again, there are a whole lot of issues with the heterozygous reports that come in, VUS that comes in. So again, it requires experts who are working in that field to tell you how to go about it and how to decide how the management aspects of it. We need it not just for the diagnosis and the management for that patient. For example, conditioning toxicity, etc., donor conditioning toxicity. For that patient, it would depend on that report. Donor screening, a lot of patients would be, the donors would be pre-symptomatic. So it has to be, the molecular testing has to be done in the sibling also before you decide or finalize which person to take in the family as a transplant donor. Prevent to organ damage, what is the focused screening that is required for that particular patient? What is the cancer surveillance that is required? All of this is important. That all of that is going to come from your molecular report. And there was also some work which were done, which actually told you where there's a kind of an AI prediction model, which looked at whether based on these features, even if you do not have a molecular report, can you actually predict that this is marrow failure, inherited marrow failure, and it's not acquired or it's not MDS and so on. So among all the top features that they looked at, so their topmost features which came out after multivariate regression was telomere length, isolated abnormal cutaneous findings, presence of multi-organ or like multiple phenotypes like cardiac renal involvement with cytopenia, young age, persons with physical anomalies, mucocutaneous triad. So typical things if you have, definitely the AI would pick up it as marrow failure. But for us, the difficulty is in patients who do not have this or patients who have some of it and the molecular report is not corroborating with us. The only negative predictor was the presence of a PNH clone. So this is basically in patients who are coming to us with aplastic anemia kind of presentation, marrow failure. So if you have a PNH clone, the presence of the PNH clone would actually be considered as an exclusion for the diagnosis of marrow failure. It is actually correlating with an immune aplastic anemia, like we know. Now, coming from the diagnosis to the management aspect of it, it's kind of a lifelong diagnosis, a lifelong management once the diagnosis is established. The parents have to be clearly informed that it's no longer only hematological or management of malignancies or immunological conditions. There's a whole lot more of screening for organ dysfunction, psychosocial, fertility, quality of life issues which are associated with this, and age-related issues, transplant-related issues, all of them have to be counseled to the families. When do you transplant? So unlike in other hematological conditions, like you have a diagnosis, yes, you need to go for transplant. Here, for some of those conditions, like for example, severe congenital neutropenia or patients with CAMT, yes, it's a straightforward diagnosis, decision to treat with transplant because the other options are hardly any. But for conditions like, for example, DBA or an FA, there is a period where the patient might be okay or patient can be managed without a transplant. So this kind of decision making, the pre-symptomatic period or the patient time where the patient window where the patient can be managed without a transplant has to be individualized for each patient. And we need to get to a transplant and not to delay further. Again, a lot of patients who get picked up as Fanconi are put on transfusions and anabolic steroids, and the family does not understand the severity or how the disease is going to progress. So by the time they get to a center for transplant, often that is already irreversible damage. It's either alloimmunization or patients who have bad neutropenic infections like fungal infections and so on, or refractory thrombocytopenia, etc. That causes of death. Transplant, again, this has to be told that it does not resolve all the issues. Some of the conditions, some of the organ involvement, like for example, lung, can potentially worsen with the conditioning and GVHD. That will happen. So the window to transplant has to be individualized for each of these diseases based on the mutation also that we are encountering. So for stable FA, patients who are on anabolic steroids, regular management, regular monitoring, a yearly marrow morphology, cytogenetics, head and neck surveillance, etc. Head and neck surveillance starts in the adolescent periods upwards, but the yearly marrow morphology molecular cytogenetic evaluation has to be sent for evaluation of AML, as well as MDS clone has to be looked into. We must remember that stanozolol or the danazol response is not something which is going to be there forever. Patients do lose their response, or they have unacceptable toxicity to it, in which ways at some point you will have to stop it, and then they come back to square one, and so it's better to transplant them early rather than late. DBA, again, similar condition. So traditionally, if you are steroid responsive, why transplant? So that's the question. The only thing is that steroid response, we must understand and counsel as well that it's again not something that's permanent. We may lose the steroid response down the hill, and a lot of patients do progress to aplastic anemia in later ages, after which transplant would be way more difficult than transplanting them early in life. Similar for other conditions as well. So that window of transplant has to be discussed with the family, and a conscious decision has to be made as to when the donor should be identified, funding should be worked up, so that we get to transplant when we want to do it. What are the non-transplant options as a non-transplant biasing? How do you stabilize the patient till you get to a transplant? Cytopenia, one of the tried and tested models for FA and telomere biology disorders, is androgen. It stimulates erythroid progenitors in the marrow. It increases the erythropoietin production in the kidneys and activates erythropoietin receptor on the stem cell. So it increases the cytopenias improve. It improves both hemoglobin as well as platelet count. And it is something which has been used for many, many years. And even in earlier ages, when you did not have NGS, aplastic patients would be put on it, and some patients would respond. So probably those responded were the ones who had either telomere biology or FA kind of conditions. There are many options to use in these patients. And more than 70% of the patients would respond, at least initially and at least transiently. And some of them, we will give you a period where you can actually keep the child stable, transfusion free, and then quickly get the other things ready for these patients. So oxymetalon, stanozolol, danazol, these are the usual agents that are used. Interestingly, the dose which is used in FA is much higher than what is required in telomere biology. So telomere biology disorders, they're more sensitive to anabolic steroids. Response, usually we get it in around the first 2 to 3 weeks itself, you'll start seeing a response in hemoglobin as well as in platelet count. And if they don't get a response till 6 months, there's no point in continuing indefinitely. It just adds to the hepatic toxicity. So it can be stopped after that. So generally, we started when the patients have a hemoglobin less than 8 and platelets less than 20K. If it's above that, then you don't need to do anything. Just wait and watch would be fine. But if it's falling below that, definitely start while you're getting them ready. And all patients should be followed up for lipid profile, thyroid profile, liver, hepatic ultrasounds for peleosis, as well as X-ray for bone age. And this is how quickly the response often comes in. There are studies where, it's just not responding. It is just not more than I think not just 70%, even more than that, patients may have response to one cell line or the other at times. Danazol is again used very frequent or commonly, one of the most commonly studied androgens in telomere biology disorders. And here again, when you use it, the earlier studies were actually halted because their improvement in telomere length was also demonstrated. So it was actually a no-brainer, and you could actually use it left, right, and center in these patients. The telomere length would improve, that the cytopenias would improve, and patients would be really doing well. Only thing is, there's a lot of toxicity associated with. So the acceptable toxicity, or generally we get to a dose where the patients are transfusion free. You don't need not achieve normal hematological, as in you do not want a remission as such. You just reached maybe around 50, 60,000 platelets and hemoglobin above 8, and that's done. The child can go to school, have all the activities, and then bring down the dose to the least toxic dose. So usually children will have deepening of voice, pubic hair growth, and acne. So toxicity in the liver toxicity, definitely you need to stop these drugs. Behavioral changes, of course, with the androgen effect, and hepatic tumors, liver ultrasound has to be looked for. So this kind of the peleosis means pool of blood. So that kind of vascular tumors are common in these conditions. So it should be looked for. And of course, they will grow a bit and then they stop because there will be premature epiphyseal fusion. So this is again another patient of FA who had this kind of huge liver SOL. Extremely difficult to get to a diagnosis because they are severely thrombocytopenic patients. When you stop, if you're on stanozolol, you stop it, then you become further thrombocytopenic, and then to get a liver biopsy, even an FNA becomes very tough in these patients. So these are the various studies of androgens. You can see the response is uniformly above 70%, although there is toxicity associated with it. And the response, to telomere length also, you can see how it responds post-treatment in these patients. With TERK patients will have better response than the DKC1 patient. So learning point is that it can be started as a stopgap arrangement, but it does not cure marrow failure. It does not prevent AML or MDS. It is the hematological response differs in certain ages. So some patients would respond initially, then you stop it. If you try to re-challenge it after a few months when the liver, etc., improves, then you don't have a response at all. So it's completely unpredictable and probably effective more early than late. So that's again, many patients lose their response as they grow older. So 4-5 years down the lane, suddenly there is no response at all. So it's probably because the marrow reserve is completely empty. The other drug which has been used in Fanconi is metformin, and these are agents which actually improve hematopoietic function. There are small studies, but they are found to be at doses of like 500 mg BD or 1000 mg BD, which is a stiff dose. There is response and there has been improvement in the hemoglobin production. So this is how not just hemoglobin, even the platelet response, neutrophil response have been seen. So in these patients who are kept on metformin for Fanconi anemia. Another new drug which has come up recently is quercetin. So the phase 1 data came out last year. So it's from Cincinnati. So this is something which I think a lot of gyms or people who are into health and wellness use this as a capsule, which is it's basically a flavonoid, but it has been found to improve hematopoiesis. It improves the hemoglobin values, platelets as well, neutrophil counts also to a lesser extent. And most importantly, the authors hypothesize that it is an antioxidant, so it will reduce the oral cavity, the risk of malignancy in the oral cavity and in the gut actually comes down. The chances of squamous cell carcinoma would come down. So this is ongoing work, and probably that phase 2 study, which is ongoing, will help us understand whether it can be given to our patient on a regular basis. As of now, it is safe and it improves the hemoglobin to a little bit extent. Another bridge therapy, what we can try is L-Trombopag that has been shown to improve counts in these patients. Cellularity overall, it helps in other aplastic anemia patients. It improves the marrow cellularity, and it has been shown to respond. All the 3 cell lines have been shown to improve. In DBA, steroids definitely first line. Few things as when you started in a pediatric age group. In infancy, the response is poor. It responds the classical age group of like 3 to 5 years when a DBA would come in. Usually, the response is generally good. So around 40-50% patients have excellent response to DBA, to steroids. Prednisolone is a good agent. Only thing is, after the response, so traditionally we go up to a good dose and then you start tapering, bring it down very, very slowly, keep it on a very small dose of probably even 2.5 mg or 1 mg once in a week. That kind of dose also is often effective to keep the hemoglobin stable. Issues are there is long-term steroids definitely would have issues like lenticular toxicity, growth, etc. PRCA or DBA per se would have growth issues. On top of that, when you give chronic steroids, that can add to the growth effects as well and long-term osteoporosis as well. So that's the difficulty in point number 1. Point number 2 is in infancy, if you use it, first of all, it doesn't work that much. You are usually reliant on transfusions. Second is using steroid in very small children have been found to affect brain growth as well. So it is not really recommended at that point. Point number 3 is when you use steroid in DBA, many a times again you lose a response. So children who responded initially very well, after a few years suddenly stop responding, and then you are back to square one. You need to get them to a transplant. So by that time it becomes difficult actually. So many a times this is a decision which has to be made as a combined decision with the family, that we are on this drug. The drug is working also. Right now it is working, but there is no real guarantee that it will continue to work. If it does not work, cyclosporin is an option definitely. Steroid refractory, steroid transfusion dependent state, transplant definitely. In those patients who have predominant neutropenia as a presentation, whether to use GCSF or not, many patients would respond transiently to GCSF. So if you have a severe infection like as orbital cellulitis or a fungal infection, maybe you can try for few doses can be tried. The whole concept of giving high mega doses of GCSF, it may work, but it has a lot of points against it also, like it would probably increase the risk of MDS AML as well in these patients. So those ones who have GCSF receptor defects would require higher doses, and the risk is there. And the risk is there irrespective of whether you use GCSF or not, but then it's not something which is going to really help in a big way. Serial CBCs are usually advised in SCN management, marrow annually to look for clonal evolution as you would do in other patients. And patients who are requiring high doses or recurrent infections, the typical mutations like CSF3R mutations, monosomy 7 definitely transplant them early. And finally, transfusions, I think the transfusion cutoffs are similar to what you would do. Iron overload is a big concern in patients with marrow failure syndromes and alloimmunizations as well. So drug of choice for iron overload is deferasirox. Only thing is there are renal and hepatic toxicities that need to be washed out in these group of patients separately. Monitoring, CBC definitely. Marrow monthly once, and what do you look for in the marrow is like patient morphology as well as molecular cytogen. So that like clear guidelines on how to evaluate these patients for this thing, how to evaluate for evolution of MDS as well as for clones which are there, which would probably require early transplant. Lot of organ involvement has to be kept in mind. So it is a multidisciplinary team that is involved. So a growth evaluation, evaluation by an oral head and neck people have to be they're part of your team. Examination by dentist, oral surgeon, nasal laryngoscopy very early in life has to be started annually. Cardiac evaluation, gastroenterological evaluation, genitourinary, genetic counseling, psychosocial evaluation, all of that comes in as a huge group of things to be done for that patient very early. And again, family should be aware that transplant cures a little bit of this only. The rest of it continues lifelong for these patients. Idiopathic pulmonary fibrosis is a specific concern in DKSA. Very limited treatment options for them. Smoking accelerates this lung damage. So smoking has to be, they have to counsel them to stop smoking. And there are some agents which will retard the deterioration of the vital capacity, but these are very expensive and very difficult to do it in long term. Danazol treatment has been shown to stabilize the vital capacity during the period of treatment. And usually once pulmonary fibrosis sets in, it's usually chronic lung disease. It's a downhill course after that. Lung transplant has been tried in few patients. Surveillance for malignancies, I said already discussed MDS AML group of disorders. If you have MDS on board, do you treat them separate differently? Generally, no. Generally, cytoreduction, there is always an argument whether cytoreduction followed by transplant or direct transplant. There are discussions both way about it. Basically, for the period that you're securing a donor, probably you would give them some chemotherapy to keep them stable till the time you identify a donor in these patients. Lot of other malignancies on board, so periodic evaluation is required in these patients. And head and neck cancer actually increases after transplant, especially if you have had GVHD in these patients. The risk of cancers in FA per se, in any cancer is 20 to 50% increase. AML is 300 to 800 fold increase, and certain malignancies like MDS, for example, is 5,000 fold increase. So you just imagine it's like a complete, it's a patient who's going to have a lot of malignancies during that period, and that has to be told. And certain conditions, certain FANC, again, one more reason why you need a genetic diagnosis earlier on is that many a times these mutations like FANG-D and all, their risk of malignancy would be so high that you would have malignancy before you would have cytopenia. So the patient is straight away coming to you with a brain tumor or Wilms tumor, etc. And you may have to, unless you have a family history, unless you look in deeply for phenotypic features, etc., sometimes a small clinodactyly or a bifid thumb, etc., may be missed. From the cancer point of view, HPV vaccination, this is something which is recommended for boys and girls nowadays. But in earlier age, when it used to come in, it was this Fanconi was the only condition where you would actually advise in both sexes HPV vaccination to reduce the risk of oral and gynecological cancers. Avoid smoking, alcohol, etc. Definitely limit sun exposure, sunscreen, skin protection, etc. Now coming to the last bit, which is on transplant, the only curative option, and it does not solve the non-hematological part of it. So patients who have severe marrow failure, patients who have clonal cytogenetic abnormalities, which would require transplant early BMT is indicated. Early BMT has been statistically shown to be beneficial in FA, DBA, SCN groups of patients before you have transfusion dependence, before you have androgen exposure, before organ dysfunction sets in, or before AML MDS. Definitely outcomes are going to be very good. Patients who, it has to be a shared decision, definitely. And there are families who would decide not to do a transplant. When you hear the whole lifelong morbidity associated with following up these children. So there are many families who would tell not to do treatment at all. Preparative regimens in patients, the best donors are, of course, matched donors, matched related donors, then matched unrelated, and then haplo. Marrow is a better graft source because of lower risk of chronic GVHD, secondary malignancies, and better long-term outcomes. Preparative regimens, low dose or reduced intensity conditionings with irradiation-free or very low dose irradiation, low dose cyclo exposure, and followed by T-cell depletion to reduce. You do not want to have GVHD at any cost in these patients. So there are papers which have now shown radiation-free conditioning in Fanconi, and this was an algorithm which was put up as a treatment plan which was put up by Dr. Farinda Mehta on how they follow at Cincinnati patients with less than 18 years marrow failure cohort, AML cohort, and more than 18 years. It's basically BU followed by cyclophosphamide, fludarabine, ATG, and a T-deplete graft. And then no cyclosporin is given to these patients. Post-transplant, they are using as a cytidine from day 42. HSCT, when in haploidentical patients, if you remove the pre-transplant cyclophosphamide, that has been found to improve the mucositis, and that did not interfere with the engraftment in these patients. And serotherapy also improved overall survival by reducing severe acute as well as chronic GVHD in these patients. Again, one big group from Kamim Bonheim's team, who has published protocols on how they do matched donor as well as matched sibling donor as well as unrelated donor transplants with very good outcomes in terms of 95% 5-year overall survival rate in these patients. So irradiation is not necessary for engraftment in this group of patients, and low dose cyclophosphamide has been used in this patient, and they use ATG and alemtuzumab in their cohort. And then finally, I think this is the protocol that they have shared on haploidentical, where they are using cyclophosphamide free regimens. And finally, during the transplant part, the supportive care part as well is very important. Like in any child, probably yes, but in addition to that, skin care would be difficult. A lot of toxicity, epithelial toxicity that you would encounter while treating these children. Nutrition has to be taken in care. Many a times you would resort to TPN during the transplant period. Many patients would be platelet refractory at that point of time. And so in a couple of patients, we have tried bortezomib prior to get the HLA immunization reduced so that during the transplant period, the platelet requirement can come down. Many patients would come to you with already an IC bleed, or patients have had life-threatening bleed. So here again, platelet levels should be kept high during the transplant period. Hypertension is an issue. Endothelial toxicity is an issue. Infection prophylaxis, not just the regular infection prophylaxis. Many of them may have MDR sepsis on board, so that has to be taken into thing. Iron overload may interfere with your liver function during the transplant. Risk of VOD would be high, and of course, GVHD prevention. Long-term GVHD prevention has to be kept in mind. Post-transplant, again, a huge list of conditions that to look out for. Almost all organs, a lot of clinics the patient should be walking into to look after each and every part of this, including fertility, quality of life, etc. Lot of malignancies that you would watch out for. Not now that the transplant is over, probably less for the hematological part of it, more for the solid organ risk. And head and neck cancers, gynecological SCCs, non-melanoma skin cancers have been known to increase post-transplant, and they're not related to HPV, so you cannot prevent them only with vaccine. And it's probably related to the time post-transplant. So as every year increases, actually the risk of solid organ cancers actually increase. So this is long-term data, which has shown that after 5-15 years, actually the patient's quality of life is still bad because your solid organ tumors are there. So these are things which should be told to a family when you take them up for a treatment. So it's not like transplanting a thalassemia or transplanting an aplastic anemia, idiopathic aplastic anemia. There's a whole lot more to it. So again, the cancer outcome and the survival free of cancer, if you look at it, for every disease, it's by the time they're 50-60 years of their outcome is actually very poor in FA patients, even patients who have received a bone marrow transplant. Gene therapy, I'm not getting into it because we don't have much time, but this is something which is in the offing. Definitely, there are studies which have looked at all the different ways of doing gene therapy as well, and it should probably be easier to get it done without the risk of GVHD. And probably once it comes in, that would take precedence over patients undergoing transplant. And finally, before I finish, just finishing with a case that all marrow failure actually need not be inherited, and all of your cytopenias, all marrow failure need not be any of these conditions. This could be something different as well. So we recently had a child, 7-month-old baby, who was brought in with fever, some respiratory symptoms, some soft tissue infection on the skin, and neutropenic child. So as in hemoglobin of 5, transfused outside, MCV high, neutropenia around 1000 neutrophil count. And later, so this is a 7-month report, and by 1 year, it's like almost 500. Platelets on the, not very low, but it's like on the lowest side. Slight developmental delay as well. So it was typical marrow failure for us. So it's looked at high MCV, cytopenia, infections. It's typically marrow failure. It should come out as one of them. But again, we had a surprise. So it was marrow failure, myeloid leukemia, megaloblastic, the DDs that we came in mind. Marrow, if you see, marrow again was hypocellular, retic is 0.3, and myeloid erythroid precursors were low. The report turned out to be something completely different. It was a metabolic disorder. It was an LMBRD, again, deficiency, which I knew about metabolic megaloblastic anemias, which had an inherited cause, but this was again something very new. This was a condition. So it had I'm sorry, it's not coming up. So it was reported as a VUS, but then we went ahead and we got it tested in the parents, and there was it was corroborating, it was segregating in the family, and this for patient. So it is a condition, it's a metabolic mimic of marrow failure syndrome. in this group of patients, it causes not just cytopenias and marrow failure, it causes also hypotonia, developmental delay, seizures. So it's one of those metabolic B12 metabolism disorders. The only interesting thing was the treatment is not transplant, the treatment is hydroxycobalamin. So they won't respond to your regular methylcobalamin. This is very high dose of like 1 milligram hydroxycobalamin. And interestingly, we've been treating for the last 6 months or so, and the hemoglobin has actually stabilized. He has not received a transfusion in the last 3 months or so, and his neurologically also is improving. So all that looks like marrow failure need not be marrow failure. Again, a reason why to evaluate them further. So it is a heterogeneous and a dynamic group of disorders. Early transplant definitely prevents irreversible organ damage. If you delay it, then not just from a clonal evolution point of it, everything just worsens with time. It's a very miserable disease group of disorders to have it. So early transplant definitely should be counseled to our family. And so at least from the hematological point of view, we can get them to a cure. So this is our team, and I thank you all for a patient listening. Thank you.
Thank you, Dr. Neeta Radhakrishnan. Very, very educational, learned a lot. So many points which were so important for clinicians as well as experts in this field. You brought us up to date. Any questions for Dr. Neeta? Yes, Dr. Gurpreet.
Thank you for a very nice lecture, ma'am. My question was that as a pathologist, ma'am, when we are seeing cases of these children who are presenting with cytopenias and may or may not have the physical stigmata, what are the things we should look at where we can say that this may be a case of inherited marrow failure syndrome? What should we keep in mind?
So from a peripheral smear or a CBC point of view, high MCV definitely. So MCV can look at age-based cutoffs and see whether the MCV is higher than expected. If you're not getting a megaloblastic correlate with just macrocytic anemia, there is dysplasia in the marrow. These are definite patients where you need to evaluate them further. If you have a clinical history where they are showing cytopenia with some organ involvement, some skeletal manifestations, all of them definitely get them evaluated. So from a marrow perspective, you're getting a marrow sample. From that marrow sample, where if there is features of MDS or if there is early features of dysplasia, low MEX, dysplastic MEX, if these things are coming in, advise evaluation further. You may not be able to, everybody may not be able to get a genetic testing or chromosomal breakage immediately, but at least if you put in a rider, they will keep it in mind. So many Fanconi patients who come to us, as in by the time they are like 10, 12 years, they have proper cytopenias. If you ask them, have you had low platelets before? They will say, yeah, 5 years ago, I had fever and got a CBC and the platelets were low and we were told it is dengue fever. So any thrombocytopenia with fever in our country is labeled dengue or malaria. So if you go back to that CBC and see, it's very classically like 80, 90,000 platelets and high MCV. So it could have been picked up then as well. So it requires a very high index of suspicion. And I think when it comes from the pathology with the label like the label or at least a statement that this needs to be looked out for, the clinician will be more attentive.
Thank you. Dr. Gopinathan, you can ask a brief question. That may be the last question.
So, there's one, good evening, ma'am. Thanks for that nice talk. There is one lady who's presented in the third decade of life. She's currently 33-year-old, and she has now got transfusion-dependent anemia. Prior to the presentation to a hematologist, she had disseminated tuberculosis. Marrow is showing erythroid hyperplasia, and interestingly, this patient, when we are working up, it turned out to have ligase 1 deficiency. So how would we manage this transfusion-dependent anemia now? So she is already post-steroids, erythropoietin, thalidomide. So how would you approach anemia in this patient?
Ligase 1 deficiency per se, do you think that is the reason for the transfusion dependency?
Looks so, ma'am. Looks so, because along with ligase 1, she has got other two named genes. She's a bit dysmorphic also. She has some kind of prognatism. She has an ASD that has got corrected in her early infancy. So I would like kind of take this variant to be slightly significant.
Because that is typically known to present early in life with infections. That is the usual presentation of ligase 1. So definitely, if it is transfusion dependent and if there is nothing else, if you can offer transplant, I think that would be the best way to get about it. Otherwise, manage like any other transfusion dependent anemia with all the comorbidities associated with managing with chelation and all of that will also be a difficult thing. But the infections also now going to increase, right? So if it is possible and if it's stable enough, probably early transplant would be beneficial.
Thank you.
Thank you, Dr. Gopinathan, and thank you, Dr. Neeta. Wonderful. You spared your valuable time to educate us. Thank you. Move on to the next lecture now. I'll just share my screen. So we have Dr. Ranjana Advani from California. I don't think she needs introduction to the crowd who is listening to her today. However, I will have to complete the formalities. She is the Saul Rosenberg Professor of Lymphoma, serves as the physician leader of the Lymphoma Clinical Care Program, and she specializes in research and treatment of Hodgkin and non-Hodgkin lymphomas, has developed a broad collaborative investigative program encompassing clinical trials and translational correlates. She is the principal investigator of numerous clinical trials. She currently serves on the NCCN non-Hodgkin and Hodgkin lymphoma. She's chair for that. Lymphoma Core Committee of the ECOG and National Cancer Institute Lymphoma Steering Committee. Board certification is American Board of Internal Medicine, Medical Oncology, 2009. Fellowship, Stanford University, Hematology and Oncology, 1996. Residency, Stanford University, Internal Medicine, 1990. Internship, Santa Clara Valley Medical Center, Internal Medicine Residency, 1987. Medical Education, Bombay University, 1982. She was on a very important subject, that is ASH Clinical Lymphoma Highlights. So I'll stop here and hand over the platform to Dr. Ranjan.
Good evening, everyone. And Dr. Agarwal, thank you for inviting me to do this lecture. I am going to share my screen with you all in just a second. Can you see my screen?
Yes.
Okay. It's a fairly long lecture. So what we'll do is I'll go through the lecture and we can reserve questions for the end. Will that work?
Yeah, sure.
Okay. So these are my disclosures. Let's start out with aggressive lymphoma. So at ASH in December, we heard some updates on frontline therapy and incorporation of novel agents, a chemotherapy-free approach for elderly and frail patients, some stuff on relapsed refractory disease, primary mediastinal lymphoma where checkpoint inhibitor was tested in frontline therapy, and then the emerging role of circulating tumor DNA to measure minimal residual disease. Now, we have lots of new drugs available for relapsed refractory large cell lymphoma, and the mechanisms of actions differ. What you all know are the CAR T cells, where you can see that they are CD19, CD20. You have the bispecific antibodies, CD3, CD20, and the ones which are available, at least in the US, for large cell lymphoma, glofitamab and epcoritamab. You have the BTK inhibitors, you have BCL2 inhibitors, then you have something which the proteasome inhibitors, the antibody drug conjugates, and of course the CD19 antibodies or CD20 antibodies, which are monoclonal, rituximab, obinutuzumab, and tafasitamab. And if you look at the NCCN guidelines, in frontline therapy, it's still R-CHOP or polatuzumab R-CHIP, depending on the IPI. And if you look at where these novel agents are, it's mainly in second and third line. So, of course, we all know that if you relapse within a year, CAR T is the standard of care now if it's available. But you may have a situation where you don't have CAR available or the patient is not a candidate. Then that's where I think the standard has changed. It no longer is our GEMOX and trying to take the patient for transplant. It's actually a combination of chemotherapy or with one of the bispecifics or with polatuzumab. And all these other agents like, selinexor or loncastuximab, these are all now in third line therapy as other recommended regimens. So I'm going to start out with some different study designs. So a few years ago, the MD Anderson group, Jason Weston, published on what he called Smart Start. Now, we know that there were lots of trials which have been done looking at combining novel agents with R-CHOP, and none of them have been positive trials. So this was a question they asked, how to you attempt to bridge and personalize the gap with a trial by using novel agents based on cell of origin with a window design, and they just did it with non-GCB DLBCL. And instead of combining it with chemotherapy, which might dampen the effect of the of the novel agent, they came in with a window design where they gave 2 cycles of just the novel agents. So they gave rituximab, ibrutinib, and lenalidomide. And after 2 cycles, came in with the chemotherapy, either CHOP or EPOCH. And the median follow-up was about 3 years. And you can see excellent 2-year progression-free survival, 91%, overall survival about 97%. And these were the standard patients we see. About a third had high IPI, and about 2/3 had stage 3 or 4 disease. So of course, then the next step was, can we use this response to targeted agents to reduce the amount of cytotoxic therapy? So this was Smart Start, but what was presented at ASH was a different concept called Smart Stop. So what was Smart Stop? So in Smart Stop, the novel agent was this LTRA regimen, which was lenalidomide, tafasitamab, rituximab, and acalabrutinib. And they had 2 study designs. In the first one, they get 4 cycles of the novel agents, and then they get a PET scan. And if your PET scan, you're a complete remission, defined as a Dovell 1, 2, or 3, you get 6 more doses of the novel agents, but just 2 cycles of CHOP. Whereas if you're a PR or stable disease or even progressive disease, you get a full 6 cycles of CHOP chemotherapy. So asking the question, if you are in a CR after novel agents, can you reduce the chemotherapy? And in the next phase, they got really bold and asked the question, well, if you're in a CR, can you drop chemotherapy completely? So this was 61 patients, median age 61. Most of them were high stage, high IPI, and about 2/3 were non-germinal center. And you can see that the median planned doses, lenalidomide was about 88%, which is not surprising, but the tafasitamab was delivered at 93%, adriamycin at 100%. Okay, and you can see that we go into how many patients got CHOP or not. Main toxicity was neutropenia, 57%, and then some rash and some infections, but nothing out of the blue, which we didn't expect. So what are the primary results? So the first result is what is the CR rate after just the novel agents, and then the second one is CR at the end of treatment. So CR rate at just after 4 cycles of the novel agents, you can see the CR rate is 33%, but the overall response rate is 57%. And that, when you come to the end of therapy, whether you got just 2 cycles of CHOP or you got 6 cycles of CHOP, the CR rate goes up to 96, so about 97%. So suggesting that, at least in some number of patients, you can get rid of the extra chemotherapy. So if you just look at the how many that sort of works out to, you can see that the progression-free survival is like almost 100%. And in the second cohort, where you don't give chemotherapy at all, it is lower. It's not 100%. But then once they progress, at whatever time, you can come in with chemotherapy, and then everybody responds. And then the progression-free survival is 86%, overall survival 98%. So basically, the conclusions were that at the end of therapy, I showed you the high CR rates as well as the high overall survival. But the strategy is that more than half the patients, you could reduce or get rid of the chemotherapy completely, because 57% CR after 4 cycles of LTRA, out of which 89% had a durable CR. So after 2 cycles of CHOP and 6 cycles of LTRA, 19 patients were treated that way. Nobody progressed. Okay, and if you don't give any CHOP at all, there are some progressions, 4 out of 16, but they all responded to adding Rituxan chemo at that time. So at the end of the day, the results were excellent. Now, the novel agents have been still, the quest for having R-CHOP X still continues. So at ASH, we heard data about a new cell mod called golcadomide. I'm going to just call it Golca. So that's also it's an oral agent. It induces rapid and deep and sustained degradation of Icaros and Aiolos in the proteasome pathway, leading in it modifies that and goes through the garbage sink, the proteasome pathway, leading to the immunomodulatory effects. And you can see that in this trial, it was a phase 1, so it was dose escalation, 3 different doses of golcadomide, but then it was combined with standard R-CHOP 21. Standard study design, 67 patients. In part 1, there were IPI 0 to 5, but in part 2, they restricted it to IPI 2 to 5. Again, the median follow-up is 2 years. The toxicity was very similar to R-CHOP, and 97% of the dose intensity of chemotherapy was maintained. And this just shows you the 2 different doses, the 0.2 milligrams and 0.4 milligrams. And you can see that overall, it's mainly the hematologic toxicity. Now, if you look at the results, the 0.4 dose had a higher complete response rate. You can see the CR rate was 88% in high-risk patients, in GCB, in non-GCB. And at 2 years, the progression-free survival was about 80% in overall as well as in high-risk populations. And they seem to be durable. They did check MRD. It was negative, and it was negative in 90% of patients, irrespective of the cell of origin. And this sort of supports the ongoing trial called GOLSEEK, which is a phase 3 trial comparing Golca R-CHOP to placebo R-CHOP. Moving on to the bispecific antibodies, we, at least for large cell lymphoma in the US, we have Glofit and Epcort available. And then for low-grade lymphoma, mosunetuzumab. For ALL is blinatumomab, and odronextamab is approved in Europe. So when we all in our practice see elderly unfit patients who are not going to be able to tolerate anthracycline, or their performance status is pretty low, so in that patient population, the elderly or the unfit patients, for untreated frontline DLBCL, this trial reported on fixed duration of subcutaneous mosunetuzumab as a single agent. Okay, this is the phase 2 Morning Sun study. So about 50 patients, median age is 82. Cell of origin, most of them had non-germinal center. Most of them stage 2 to 4. Half of them are high IPI. It was very well tolerated. There was no ICANS. There was very little CRS, mainly grade 1. The main side effects were infections, and this was again done in the COVID era, but 14% had grade 3 pneumonia, and about 16% discontinued because of the Mosun side effect. But this was a standard dosing where you do step-up dosing from 5, 45, 45, and then you stay at 45, and the Mosun here was given subcutaneously in the step-up dosing. And you can see that in the overall population, the median duration of response and the duration of CR were both not reached. And the median time to response was about 2.5 months. And you can see that the median time to next treatment was not reached. So if you just look overall, the CR rate is 59%, overall response rate is 73.5. And if you look at, all stages across cell of origin, all IPI, and this is, you can see here, the median has not been reached, but 12-month PFS 71%, overall survival 75%. So remember, this is not chemotherapy. This is single agent bispecific. And at least in certain patients, there seems to be, after about, 8-10 months, say a year or so, there seems to be a plateau. And these results are very encouraging and suggest even a reasonably good MRD negative rate. And I think this is being tested more in broader experience. So that was with mosunetuzumab. Well, what about epcoritamab, which is another bispecific? So same thing. This is now, again, patients had to be 80 or over or 75 with a comorbid condition. Now, this is just epcoritamab by itself. The second arm of the trial was not started. 66 patients, again, high median age, 64% high IPI, 3 to 5. They did seek a CRS, but it's mainly in cycle 1, and most of it was grade 1 to 2, treated with, but about a third needed tocilizumab, 28% needed steroids. They had some ICANS, 18%, but which resolved. Again, the main side effect, infections. So grade 3 was only 18%, again, done in the COVID era. And 78% of the complete remissions were ongoing at 1 year, and the MRD was negative. So it's very similar to the previous trial. 54% progression-free survival at 1 year and appears to be a plateau after that. Overall survival, 65%. So you can see that the patients who achieve a CR, it seems to be quite durable, and the MRD negative rate was 90%. So single agent work quite well. Well, will it work better if you combine epcoritamab with our mini-CHOP? Now, for most of us, when we have an older patient who can get some chemo and some anthracycline, our mini-CHOP is a standard of care. So they combined epcoritamab with our mini-CHOP in patients who are elderly and again, newly diagnosed. A very small study, only 28 patients, median age 81. And the reasons for not being able to tolerate full dose of chemo or anthracycline are a little odd. One was age, which was main 96%, but they even had diabetes 11%, hypertension. So that's a little flaky, but nonetheless, they didn't report on echo being bad. They reported on diabetes and hypertension. High IPI, cell of origin was across both. 40% had bulk, elevated LDH, and they were treated pretty quickly, between 5 weeks from diagnosis, suggesting that they were a pretty sick population. Again, no ICANS, CRS seen in 61%, and EPCOR had to be discontinued because of the treatment adverse events in 11%, and about 21% could not finish our mini-CHOP, again because of treatment emergent effects. Not a very good idea to combine the two. However, the overall rates and CR rates were very high, and the MRD rates were also very high. The progression-free survival, you can see 76% remain alive at 2 years, and the overall survival is also very good. But remember, a lot of discontinuation and infections. What about a completely different way of treating elderly patients? So this study looked at combining all novel agents, but sort of a chemotherapy-free approach. So they had a pre-phase with steroids, and then a step-up cycle where obinutuzumab, polatuzumab, and glofitamab. So a bispecific, a CD79 antibody, and something CD20. And then at the target dose, so for the step-up, you get obin because you're giving it with glofit. That's how it's given. And then you switch to rituximab. And then there's some consolidation for a few cycles with glofit alone. 80 patients, again, median age is high. You can see the other characteristics. And they all had geriatric assessment. And 91% were unfit. So that sort of represented the real-world cohort of patients who are medically frail or unfit and high treatment complexity. So you can see over here that in the safety profile, 53% had no grade 3 toxicity, low treatment-related mortality, 90% are alive at the end of treatment. You can see over here that the response over time is pretty good. It's sustained. You can see that initially the CR rate is 55% after just 2 cycles, but by the end of final restaging, it's 81%. So the R-Polar Glow has an overall response rate of 90%, and 81 of those are CRs at the end of treatment. And this is very short median follow-up for 15 months. Responses seem durable with a 1 year and PFS of 85% and overall survival of 90%. So I've shown you a lot of trials, and just to kind of put it in perspective, I made the table. So with the front line where I add novel agents to a chemotherapy backbone, such as Golka to R-CHOP or the Smart Stop, you can see that the PFS is running in the 80 to 85% range, and the MRD negative rate when reported is really high. For elderly or frail patients, when you have either the bispecifics alone or add chemotherapy to it, or you have the R-polar glofit, you can see that the 1-2 year PFS is, depending on what you're doing, with EPCOR fixed duration is a little lower, but in the others it's about 70%. And you can see that the CR rate is quite high, a little lower with Mosun, but the median duration of response is for most of these are pretty comparable. And with the last one, the follow-up is short. That's why the median duration of response has not been reached. What about relapse or refractory disease? So this was now long-term follow-up with subcutaneous Mosun, but in combination with Pola. So remember, Mosun is approved as a single agent in follicular lymphoma in the US, not for large cell lymphoma. So here they combined Mosun with polatuzumab, which you are very familiar with, for relapsed refractory large cell lymphoma. So you can see they had to have greater than 1 line of therapy. You can see it's standard, step-up dosing. It's given subcutaneously, and it's fixed dose. It's a total of 8 cycles. Median follow-up 26 months, and the median duration of response is, and this was a randomized trial, by the way. So it's Mosun Pola versus just R Pola. Median duration of response was not reached versus 11.3 months. Median progression-free survival about 25 months versus just 6 months. And very low-grade CRS, just limited to cycle 1, day 1. So very pretty appealing data that as a salvage regimen, especially if somebody you're not going to be able to give CAR or transplant, this seems like a really reasonable option. And I think what I want to focus on is basically 3 practice-changing trials. So I showed you the data on the Mosun Pola. That was the early, phase 1, phase 2. But there was this big SUNMO trial looking at Mosun Pola, which was a randomized trial, which compared Mosun Pola to R-GemOx, because R-GemOx was the standard of care for patients not eligible for transplant or not eligible for CAR-T. And there was a progression-free survival benefit of 11 months versus just 3.8 months with R-GemOx, with a median follow-up of 23 months. There were 2 other random, and that was published in, you can see in JCO at the end of last year. In parallel, earlier last year, there were 2 other big trials. First was end of 2024, was the StarGlow trial, again looking at combining glofitamab. GemOx was the chemotherapy compared to R-GemOx. And you can see in this trial, there's actually an overall survival benefit, 25 months for glofit GemOx versus just 12 months for GemOx. And then the POLARGO trial, which looked at polatuzumab GemOx. So this is CD79 antibody, which also was a randomized trial, again an overall survival benefit, so 19 months versus 12 months. So the point I want to make is that R-GemOx alone now, given these 3 big randomized trials, is inadequate regimen for relapsed refractory DLBCL. You've got to add something else to R-GemOx if available. And this was not presented, but in preparing and in my reading, I found this paper just published where, I know we worry, well, if they failed a bispecific, and what are we going to do? Can we take the patients to allogeneic transplant? And what is the consequence? Does allo work when you've given someone a bispecific antibody? And the answer is yes. It does not compromise the safety or the efficacy of allo transplants in patients with relapsed refractory large B-cell lymphoma. And it possibly leads to a deeper remission and fewer relapses. Now, in primary mediastinal lymphoma, in the US, dose-adjusted EPOCH is the standard of care because there's no radiotherapy. What we know is that R-CHOP21 by itself is inadequate without radiation, and that was shown in the extranodal lymphoma study group, where they looked at various chemotherapy regimens with or without radiation, and whether you gave VCOP-B or if you give R-CHOP14 or dose-adjusted EPOCH, all those did fine. But the only regimen which didn't do well was R-CHOP21, and you can see, a very modest difference in PFS and modest difference in overall survival. While it's not statistically significant, just suggests that the other regimens are preferable. Now, checkpoint inhibitors are approved in the relapse setting for primary mediastinal lymphoma, and it works because PD-L1 and L2 are frequently upregulated in primary mediastinal lymphoma. And in the relapse setting, they have a overall response rate of 43%, and about half of those are CR. So the next step, of course, is because R-CHOP21 doesn't do so well, what about combining a checkpoint inhibitor with R-CHOP21? So this was a small study done by the Australasian group. You can see that there was a window, small window where they get the drug with Rituxan, and then you combine it with R-CHOP, and then there's some maintenance in consolidation. And you can see that the end of the window, the complete metabolic rate is low, but it's mainly a partial metabolic. And then at the end of induction, it goes up from 62% overall. And you can see if you take out the withdrawals, it's 69%. Progression-free survival is pretty good. Overall survival is excellent. So you can see that when they looked at MRD status, after just R-Pembro, 50% were MRD negative. So the question for future trials is, well, if they're MRD negative, what is the role of giving with chemotherapy? Can you cut down on the number of cycles of chemotherapy? The other question is, a lot of the withdrawals were because of this maintenance, the IO toxicity during maintenance. So if you're MRD negative here, do you really need the maintenance? So this was just a small hypothesis generating trial, but again, quite interesting. And moving on to where we are going with tumor DNA dynamics during and after first-line therapy. This was an update on the HOVON study, and you can see over here that this was academic sites in the Netherlands. This was newly diagnosed patients treated with curative intent with R-CHOP or dose-adjusted EPOCH, and they collected for cell-free DNA in the specific tubes like the Streck tubes. You can see it was done on treatment, it was done end of treatment, it was done during surveillance for up to 2 years. So they had 166 samples, evaluable samples, and you can see that they were able to find a phase variant in 99%, and the median follow-up is now 33 months. And you can see MRD, this is now cycle 2, day 1. So cycle 2, day 1, if you're MRD negative, which was 30% of the patients, they don't relapse at the 3-year landmark. All of them were progression-free. However, if you were MRD positive, you can see that, it doesn't dip down like this, but a substantial number of patients do relapse. What about at the end of treatment? You can see at the end of treatment, this curve is even better split. So if you're end of treatment, this looks at if you are PET scan negative and MRD negative, you do really well. But if you are PET scan negative but MRD positive, your PFS is only 36%. So when is the best time to do this? Is it when you look at all the factors? Well, yes, IPI predicts, the end of therapy predicts, but combining end of therapy MRD status with PET is the most sensitive way of predicting who might relapse. Specifically, if you look at patients who are PET negative at the end and they're MRD positive, those are the ones who at 3 years, the progression-free survival is only 36%. The question is, what do we do with that then? So one way of looking at this, and these trials are going to be generated, is if they're MRD positive at the end, can you do early interventions? Can you do a bispecific? Or should you do a CAR-T? That is being tested in the ALPHA3 trial. So can you do an autologous CAR? And because the earlier you give immunotherapy where the T cells are more fit, the better the results are. Or like I said, can you do glofitamab? So earlier lines of therapy. So, let's see where this goes. But the hope is that early MRD-directed therapy should demonstrate clinical benefit versus CAR-T given just at relapse. So there are multiple trials going on in frontline DLBCL. The red ones are the ones completed, which is Polarix, which we know the results because that's where with Polarchip is now one of the standards of care. The EPCOR R-CHOP, I heard, is being presented at EHA in a few weeks. The SkyGlow has completed accrual, and that's Polar R-CHP plus Glofit. And so I think certainly in the next 2 years, we're going to see probably a lot more positive trials, and then we'll have, like, how do we choose amongst all these positive trials? So time will tell. So the key takeaways for large cell lymphoma, high-grade lymphoma, there are multiple trials in the frontline setting with novel agents, smart designs. The chemotherapy-free or the light approach is promising in elderly. Checkpoint inhibitor with CHOP21 is promising in frontline primary mediastinum. R-GemOx is no longer acceptable as a therapy option for CAR-T or stem cell transplant in eligible patients, and MRD is a powerful prognostic marker during and at the end of treatment. Of course, it's still not commercially available, and what we'll do with a positive result, there's no defined treatment strategy, but I think that's where the field is going, and trials are being designed. Moving on to Hodgkin lymphoma. We heard long-term data on the two new frontline regimens, the SWOG 1826 and HT21 by the German Hodgkin Study Group, some newer approaches in frontline, and a novel agent in relapse disease. So, I've given Hodgkin's talks in India a lot, and you'll have seen this slide before. We've spent a decade or more looking at PET-adapted trials for advanced stage lymphoma, whether it's RATHL, where you give ABVD and you drop the bleo after 2 cycles, or you give escalated BioCop and you're PET negative, you go down to ABVD, or you just cut the number of cycles of escalated BioCop down to 4 if you're PET negative. And it established these as standard of care approaches in the US and in Europe. And then, of course, came Echelon 1, where BV-AVD improved overall survival compared to ABVD. And then that became standard of care. And the field has evolved, and now it's Nivo-AVD or BRICAD as the new standards of care. And as chair of the NCCN Hodgkin's panel, I can tell you that, in September 2024, when we were at the meeting, we all said that the primary treatment is still ABVD per RATHL or BV-AVD per Echelon 1 because of the overall survival advantage, and useful under certain circumstances with the BRICAD and Nivo-AVD regimen because they were only presented at meetings and only abstract form. We haven't seen the full publication without the peer review and to read the supplementary data. And literally 6 to 8 months later, this completely flipped. Now the preferred regimens became Nivo-AVD or BRICAD, and useful under certain circumstances, it was BV-AVD, and ABVD per RATHL was stayed on the guidelines. That's if if you're in an area of the world where you don't get BV or checkpoint inhibitors, or if those are contraindicated. So at ASH, we heard the 3-year follow-up of the SWOG trial, which compared BV-AVD to Nivo-AVD in just stage 3 or 4. And you can see PFS at 3 years is 91% versus 82%. And the benefit was seen across all subgroups. There is no overall survival advantage. Nivo-AVD outperformed BV-AVD in low IPS, in high IPS, in adolescents, in 18 to 60-year-old, and in older adults. And in older adults, it's been immediately practice changing if the patient is anthracycline eligible, because there's an overall survival benefit also with Nivo-AVD, largely because in the BV-AVD arm, a lot of patients could not complete therapy because of infection and non-relapse mortality. And BV-AVD did not underperform. It's at about 58% in older patients, which was exactly what it was in the Echelon 1 trial and no better than ABVD. In the BRICAD was a regimen developed by the German Hodgkin Study Group, comparing it to 4 cycles of escalated BioCop. And this is the study design. If you're PET negative after 2, the standard arm just stays on escalated BioCop. But if the experimental arm is the BRICAD, PET negative, you just get 4 of BRICAD. If you're PET positive, 6. So why BRICAD? Well, BioCop was not really accepted pretty broadly, at least in North America, mainly because of the toxicity. There was a secondary leukemia risk. There was sterility was a huge problem and this Hodgkin's, as you know, is a disease of young people. So that's why people were hesitant to use it. So what BRICAD did, it got rid of the bleomycin. It kept the chemotherapy backbone, no vincristine. They added brentuximab instead. They got rid of the 14 days of prednisone, which was in BA-CARP and led to, avascular necrosis of the hip and other infections. And they substituted it with dexamethasone for 40 milligrams. And they got rid of the procarbazine, which causes, firstly infertility, but also the secondary leukemia, MDS, and substituted with dacarbazine, which is also an ABVD and is a weak alkylator. And with that, that led to a 21% reduction in grade 4 hematologic toxicity and non-heme toxicity. And I think another important thing to understand is that the cumulative anthracycline dose with BRICAD, so if you get 4 cycles, it's only 160. And if you get 6 cycles, if you're PET positive, it's 240, which is still much less than the 300 you'll get with 6 cycles of Nivo-AVD. So it preserves fertility. So you can look at female patients and male patients, their hormonal values materialized, and there were actually more children born in the BRICAD arm than in the BA-CARP arm. And at 5 years, you can see that the efficacy is sustained. The PFS is 94%, and there's no overall survival to date. But you can see 2/3 of the patients, 66% of the patients were interim PET negative, so just got a total of 4 cycles. What about the ones who got 6 cycles? Well, even in that group, 6 cycles, the PFS is 90%. So excellent results with 5 years of median follow-up. So, how do you choose between the two? Well, it depends on where you practice and what supportive care you have. So this is, 6 months of therapy and only included stage 3 or 4 patients, but it did include pediatric patients and above. BRICAD was 18 to 60, and it did include about 16% stage 2B patients, but it's a much shorter time to completion. It's 12 weeks if you are PET2 negative, 18 weeks if you're PET2 positive, okay? I would say the efficacy is pretty comparable. It's over 90%. There was, of course, much less hematologic toxicity and infection in Nivo-AVD. It did not mandate GCSF, but now that it's approved, the FDA label requires it. And we know Nivo-AVD can be given safely to patients over 60. This did not include patients over 60. It was a separate trial. There was very little anemia, so hardly any transfusion, but it excluded patients with pre-existing autoimmune disease. So if you have someone with a history of rheumatoid arthritis or lupus, they were excluded. Patients with neuropathy were excluded because of the BV arm, and fertility data has not been reported as yet. Whereas in BRICAD, I told you about the less anthracycline. GCSF was mandated. There were no autoimmune side effects. There was more acute heme toxicity, and they have published quite extensively on fertility preservation. And it's, where you practice, what you can do, and what supportive care you have. That's basically what decides what you should use. And I'll kind of go through it a little bit more in a bit. The other thing which was presented was, what if you add 2 novel agents to frontline therapy? So this was actually published a while ago. This looked at, ANAD. So, I call it the kitchen sink approach. You throw everything. So they gave 6 cycles, and they basically didn't give any bleomycin, and there was no Wellban. But they added brentuximab, nivolumab, and they had doxorubicin, dacarbazine, okay? And this was early stage as well as advanced stage. And you can see over here that the median follow-up of 2 months, the 2-year PFS was 88%. And at the end of 93% CR rate, 88%. So, it was good, but I don't think these results are any better than what I just showed you with SWOG 1826 or BRICAD, which are in the 90-95% range. So, of course, then the question the group of investigators asked is, well, can we a response-adapted de-escalation? So that is what was presented at ASH. What they did now is they did a Pembro, instead of Nivo, it was Prembo BV, and the chemotherapy was AD for 3 cycles. And if you're PET negative, all you got was 3 cycles of Pembro BV, no more chemotherapy. But if you had Dovell, 4 or 5, you got the Pembro BV, and you got the full 6 cycle, and you got the full additional 3 cycles of chemotherapy. And you can see small 25 patients. It was well tolerated. There was no febrile neutropenia. No growth factors were used. The IO toxicity was mild, neuropathy was mild, and there was no radiotherapy. So at the end of just the first part, where you just got the lead in with the Pembro and the BV, and you can see just 3 cycles of chemotherapy, the CR rate at end of therapy was 88%. So those patients basically went on to just get the maintenance without further chemotherapy. So we've cut down on the number of cycles of chemotherapy, and you can see that the PFS at 16 months is 96%. So 50% reduction in chemo for patients using this modified CR at interim PET. And of course, you need to longer follow-up to see if the results are durable or not. But I think where the field is moving is now that we get such high CR rates with adding novel agents to frontline, can we cut down on the number of chemotherapy cycles? So some of the other things to consider when you are choosing therapy for frontline is, of course, what we don't know is the checkpoint inhibitors with pre-existing autoimmune disorders, what the long-term effects are, and how do you response assess when you're using a checkpoint inhibitor, because you can get false positive PET scans, and of course the role of ctDNA. And the cumulative dose, we used to think of, anthracycline causing cardiac issue, yes, but if you gave radiation, we were worried about breast cancer risk. Well, it's no longer just breast cancer because of radiation. Doxorubicin by itself is a risk factor for getting breast cancer. And a study from the Netherlands showed that the minute you cross 200 per meter squared of area, your cumulative risk of breast cancer goes up. And in this study, the risk was 19% at 30 years, just from the anthracycline, irrespective of age, with or without radiotherapy. So the reason I brought that up is because of the if you have somebody, say, with borderline ejection fraction who's young, I think BRICAD has the lowest amount of anthracycline compared to all the other regimens. Now, we're seeing a lot of patients now who have failed BV, who have failed a checkpoint inhibitor in Hodgkin's, and the question is, what do you do for those patients? CD30 CART was being developed, but the responses were not as good as in DLBCL. The development of CART, CD30 CART, has been stalled for the lack of durability of response. So this was developed by Seattle Genetics and then now Pfizer, 35C, which is another antibody drug conjugate to CD30, but conjugated to not MMAE, but camptothecin to get rid of the neuropathy. So this looked at, and it was, preclinical data looked really good. So this is what was presented at ASH. There were 37 Hodgkin's patients in this trial, which included any CD30 positive lymphoma. And 95% of them had prior BV, 95% of them had prior checkpoint inhibitor, 2/3 of them had prior transplant. Manageable safety profile. Neutropenia was the most common side effect, but no discontinuation because of that, and there was no peripheral neuropathy. So if you look at the waterfall plot, and you can see the 37 patients of Hodgkin's, it was mainly PRs. The overall response rate is 81%. CR rate is about 20%. And if you they looked at ctDNA clearance, and ctDNA clearance at after cycle 3 was seen in 92% of the patients. And all the patients who actually had a CR had greater than 90% ctDNA reduction. So again, quite encouraging. Unfortunately, Pfizer is not going to develop this because this market is getting even smaller. So the key takeaways for Hodgkin's are that the long-term follow-up of SWOG and the BRICAD in frontline therapy show durable results. I think both regimens have a place, and patient selection is important. Further de-escalation of chemotherapy by adding novel agents is promising, but you need longer follow-up, and if it holds, the concept needs to be tested in a randomized trial. The 35C is encouraging activity, but unfortunately not being developed any further. And I honestly think the bigger question is, how do we identify the 75% who do really well with ABVD and keep costs contained so that all geographies can use it? And in the US, you can see ABVD for 6 cycles is about $1,600, probably much less in India. But the minute you add a novel agent, it goes up to over $200,000. I mean, that's not sustainable. And we really need to focus our research now on how do we find those 75 who do really well with ABVD. So I think, smarter study designs, de-escalation, escalation based on MRD, And I think in India, there are reports, I've seen of Vellore using a lower dose of a checkpoint inhibitor. I think it needs to be tested in a randomized trial, and rather than just single institution data, because that will be service to the whole world if we can prove that it's not inferior. And then, of course, specific type trials. Moving on to mantle cell lymphoma. For frontline therapy, we heard about chemotherapy-free triplets, and then in the relapse setting, a new BCL-2 inhibitor. So there are lots of new drugs which are out there for mantle cell lymphoma too. Some of them are used, of course, in large cell lymphoma, the bispecific antibodies and polatuzumab. But the BTK inhibitors, whether it's covalent or non-covalent, the BCL-2 inhibitors, venetoclax or sonrotoclax, and now we have newer immunotherapies and small molecule inhibitors. And if you look at the NCCN guideline for first-line therapy, if you're suitable for induction therapy or not suitable, but if you want to have a less aggressive induction, you can see it's either bendamustine based or the checkpoint inhibitors, the BTK inhibitors, acalabrutinib is in the front line in combination with BR or just Rituxan. And if you have TP53 mutated disease, that's where the bovine regimen, the venetoclax, zanubrutinib, and obinutuzumab are in the guidelines. And of course, the induction therapy is dealer's choice. The triangle study suggests that when you add a BTK inhibitor, the role of transplant is very up in the air, and most of us don't do it anymore. So this is again a field which has evolved. So it was interesting to hear longer term data of regimens which do not use chemotherapy. So this is 5-year follow-up looking in the ECHO trial, which compared bendamustine Rituxan with or without acalabrutinib. So you can see that the blue, the ABR, which is with the acalabrutinib, is a blue line, and this is just standard BR. So the median progression-free survival at 5 years is 72.5% versus just 47%, and the CR rate was also higher. So suggesting that BR alone may not be enough, that ABR does better, especially if you have an older patient who you're not going to be able to give CAR to or take to transplant. Now, what about combining acalabrutinib to venetoclax and Rituxan? I mean, I showed it to you in combination with BR, but that was chemo. This is with venetoclax and Rituxan, and this was the phase 2 TRAVERSE study. Okay, this was presented by the Australian group, Eliza Hawks. So you can see over here, AVR inductions. And if you are MRD negative after the AVR cycles, which were anywhere from 1 to 13 cycles, there was a 1-to-1 randomization to observation versus maintenance acalabrutinib up to cycle 15. So that's still the end of treatment. And if you're MRD positive at the end of the induction, you can see that acalabrutinib is given until you have progressive disease. 108 patients, the usual patient characteristic, intermediate to high risk, and now the median follow-up is 15 months. So what are the results? So this is at any time, the overall response rate 95%, 86% had a complete remission. And at cycle 14, you can see 100% overall response rate, 94% CR rate, progression-free survival, very high, irrespective of the P53 mutated status. You can see 97%, 94%, and at 1 year, about 95%, 88%. So 93% who completed the AVR induction achieved MRD negative CR, and 82% of the MRD negative after 3 cycles, and that rate kept increasing as the treatment went on. There was no additive toxicity with the triplet, 87% completed it, and of course the future analysis will report on post-randomization whether you need the maintenance or not. Another trial which was presented was bovine. I told you in the NCCN it was just for P53 mutated. What was presented at ASH was as frontline for older patients with mantle cell, not irrespective of P53. You can see 50 patients met the eligibility. P53, about 28% of them. The rest were the usual characteristics which you see in patients with mantle cell. It was overall well tolerated. Febrile neutropenia was very low. About a third of the patients got growth factors. Infections was an issue, but most of them were COVID. Now the median follow-up was 2 years. And the primary endpoint was a 3-year progression-free survival. So keep that in mind. And what they thought is if you have a 3-year progression survival of 70%, it would be a success. So they reported the 2-year progression-free survival, which is 86%, and that certainly is encouraging. High CR rate, high MRD negative rate, good overall survival, progression-free survival. But because the primary endpoint is at 3 years, we'll see what it shows at 3 years, whether this is going to hold and stay above 70% or whether it will dip down. So again, it seems to be going in the right direction. The next study was again looking at acalabrutinib venetoclax, but with obinutuzumab. And they had 2 cohorts. They had a relapsed refractory cohort and they had a untreated cohort, which was transplant. This cohort B was transplant ineligible or P53 aberrant, which was they called high risk. And the low risk was either wild type P53 or transplant eligible. And this is a little bit complicated, so I'll walk you through it. So this is now the treatment naive high risk, okay? So with this, there were 24 patients, 71% had mutated P53, and on immunohistochemistry, 33% were positive. So if you look at the end of response, overall response rate is 88%, and most of them are actually CRs. And you can see 75% were MRD negative, and the 2-year PFS is 82%, overall survival 94%. What about the patients who were low risk? So the low risk patients, which were, you can see that there were just 12 patients, so really small. 89% had undetectable MRD at the end of treatment, and no relapse at the median follow-up of only 3 months. And you can see that at the end of induction, the overall response rate is 100%, and the PFS and the overall survival is excellent, 100%. So we know about venetoclax in relapsed or refractory setting. This is now sonrotoclax, next generation BCL2 inhibitor. Again, 115 patients, median age 88, 87% were refractory to the last therapy. And you can see all of them had had a prior BTK, okay? Median of prior lines of therapy, a third of patients were P53 mutated. And you can see over here that the response was seen across all subgroups, but the primary endpoint was met as compared to historical control of an overall response rate of 30%. Over here, it was 54%. And if you had less than 3 prior lines, it was 61%. But with a median follow-up of about a year, patients who received sonrotoclax, you can see that the 320 milligrams a day dose, the median duration of response was about 16 months, PFS 6 months, and overall survival was not reached. So just summarizing the frontline trials. So the ECHO is with the bendamustine. You can see PFS is 72.5% at 5 years. Very mature follow-up. We don't know MRD data. But the chemo-free approaches, now we have the 3, the TRAVERSE, the BOVEN in elderly, and the MAVO, which that 24 patients at high risk. You can see really high CR rates, and at least in the short 1 to 2 years, the PFS is very encouraging. You can see 80-90%, and where we've heard MRD, it's very high. So the future, I think, is going to be in mantle cell, where we're going to move to a combination of novel agents and not have chemotherapy or transplant in the mix. There are lots of randomized trials ongoing, and you can see zanubrutinib rituximab versus BR, Mangrove is going on. The TRAVERSE study is going on. And there are lots of trials going on. So I think stay tuned. So the key takeaways, the chemotherapy-free triplets are very promising in frontline therapy. High MRD negative rates allow for fixed duration of therapy. We, of course, need longer follow-up. The new BCL2 inhibitors are being developed in the frontline and the relapse setting, and there are phase 3 randomized trials going on. You have this the Celestial trial, which is sonrotoclax plus Xanu versus Xanu plus placebo in the relapse setting. Moving on to the last part of my talk now is focusing on follicular lymphoma. Here we've heard some updates or new data on using bispecifics in frontline, and then some updates on recent approvals for relapsed or refractory disease. So first is before the background, I wanted to give you this just got published as a background, the 5-year long-term update of the R squared regimen versus just R placebo, the augment trial for patients with relapsed refractory follicular lymphoma. And that's this R squared regimen sort of became the standard of care for relapsed or refractory, indolent lymphomas. And you can see at 5 years, the overall, benefit stays. You can see the progression-free survival and the overall survival are improved in R squared versus R placebo. So R squared became the standard of care for relapse disease. If you look at the guidelines now for first-line therapy, of course, it's you can do, it's R chemo, including R squared. But if you look at the second-line regimens, just look at what is category 1. It's no longer R squared alone. It's R squared with a bispecific antibody, epcoritamab, or it's R squared with a CD19 antibody, tafasitamab. Those are now, nowhere do you see R squared alone unless, it's kind of left in there if you're in an area where you can't get these. So I'm going to walk you through those data. And then for third line, of course, you have all the bispecific and CART, but you can see the BTK inhibitor also in third line. So we heard an update on why obinutuzumab is one of the other regimens. So the question is, can we now use bispecifics in the front line? So what we heard was updated data on mosunetuzumab. Now this is, remember, in follicular lymphoma, if you don't need treatment, you do watch and wait. But if you have GELF criteria where patients need treatment, the standard of care is, BR or R-CHOP or whatever, you want to use, but they need treatment. So this looked at high tumor burden patients. That means they had to meet the GELF criteria, but they used single agent fixed duration mosunetuzumab, okay, subcutaneously. And it's the phase 2 Morning Sun study. So again, it's the usual step-up dosing, 103 patients, and they had up to 1 year. And then patients who had a partial remission or a complete remission after cycle 17, they had optional maintenance for additional 1 year. And about 46 out of the 103, little less than half, landed up getting that maintenance. Median age 64, and half of them high risk flippy. So you can see over here that it was very well tolerated. You have, the small, little bit of cytokine release, but it was all in the beginning pretty well managed with steroids and tocilizumab. But I think if you look at the side effects, main thing is infections. Again, I think with bispecifics, we're seeing this as a theme, and it was predominantly involved the respiratory tracts. And I mean, they all resolved. But if you look at serious infections, it's 16%. And any grade 2 or grade 2, 47%, grade 3 is 12, which was what they considered. Again, it was done in the COVID area, so most of them were COVID. But if you look at the efficacy, the progression-free survival now, single agent without chemotherapy, you can see that the 18-month progression-free survival median has not been reached. It's 85%, and the overall survival is 91%. And a very high MRG negative rate. So again, very encouraging data and needs to be tested in a phase 3 study. What about epcoritamab? But this combined epcor along with Rituxan, okay? So this is epcor Rituxan in patients with high tumor burden, follicular lymphoma. So you can see here, 35 patients, median follow-up is about a year. So very standard. You give a little bit of Rituxan and then you give epcor, and it's fixed duration of therapy and the usual, patient characteristics. Again, infection, and 34% infection were deemed to be related. But if you look at the cytokine release, when they went to 3 step-up dosings instead of 2, it went down significantly. But more importantly, if you look at the response rate, very high complete remission rate. Just after cycle 3, day 1, it's 86%. And at the end of treatment, it's up to 93%. And you can see the median follow-up of 12 months. You can see the PFS is excellent, and the duration of response is 100% if you're in a CR, and doing very well. So remember, this is just Rituxan and epcoritamab and for frontline high tumor burden. What about mosunetuzumab? This was there in the guidelines. We heard sorry, Zanu was there with obinutuzumab. This is now combining Zanu with mosunetuzumab, another bispecific in frontline. So you can see this is oral dosing of Zanu, and then you have the standard Mosun, and you can see that again there are up to 17 cycles. Again, patients needed treatment, 54 patients, and the usual criteria. They all had to meet GELF criteria. You can see again, very deep, complete remission. CRS was not an issue, pretty well managed. Most of the adverse events were, you can see over here, a pretty low grade, very few dark blues over here. Responses seem durable. Now, summarizing all these three together, you can see that some of the patients, there are all frontline trials which are ongoing. I showed you really good data where they have deep responses, high CR rates, MRD negative, but there's still all single arm trials. So there are trials ongoing comparing it in a randomized fashion to standard of care. Okay, and they're either phase 3 or phase 2 trials. Again, high or low tumor burden. So time will tell as to what is going to become standard of care. A 5-year update was presented of the Zanu-Oben trial versus Oben single agent. I showed this for you as third line in the NCCN guidelines. This is now a median follow-up of 36 months. This was the Rosewood trial. No new safety signals. This was 43% CR versus 19%. And so now what this is doing is the phase 3 ongoing Mahogany study, which is Zanu-Oben versus R-squared. Now we can argue, is R-squared a standard of care anymore? And likely not. So what are the ongoing phase 3 trials which are using R-squared as a control arm? One is the Celestimo, which is Mosun-Len versus R-squared. The Olympia trial, odronextamab-Len versus R-squared. The Symphony trial, which is tazemetostat-Len versus R-Len. And then I've highlighted this. This is Epcor-Len versus R-squared. And was presented. The Epcor-Len was Epcor R-squared versus R-squared. A big randomized trial, almost 500 patients. You can see that FLIPI was 44%, POD 41% for they had relapsed, double refractory 37%. And you can see over here that the CRS was pretty low. It had more grade 3 events compared to R-squared, but it was manageable. But I think this is the main thing. You can see that Epcor R-squared resulted in superior progression-free survival with 79% risk reduction and a positive trend towards overall survival. CRs were deep and durable. And in the parallel, this was published in parallel at the FDA and also in the Lancet, and FDA approved. So Epcor R-squared in relapsed refractory was approved by the FDA as a regimen in the guidelines. And that's why you saw that it's made it to the NCCN guidelines as second line as a category 1. The other one which is also in the guidelines, is the tafasitamab R-squared. And you can see that the tafasitamab R-squared was the in-mind study for relapsed refractory lymphoma. And this was published earlier, but it included all lines of therapy. So what we heard at ASH was the subset of patients where it was used for second-line therapy. So standard design. So R-squared is standard, but the Tafa-Len, and you can see over here the Tafa doses, and the Len is pretty much like the prior publications. So out of the 548 patients on the trial, about half of them had only one prior line of therapy. So this would be second line. And that's the group which was presented at ASH. And you can see this is the first trial which targets 2 antibodies, CD19 with the Tafa and CD20 with the Rituxan. So you can see the progression-free survival as well as time to next treatment met its primary endpoint as being better than R-squared. And if you look at it in patients who had POD 24, it works in that setting as well. So this was, again, the first study to validate 2 antibodies, 19 and 20, in follicular lymphoma. It met its endpoint and it's now part of the NCCN guidelines. So summarizing this, frontline high tumor burden, I showed you fixed Mosen single agent. You can see that the PFS is about 85%. Then combining Rituxan with Epcor, 97%. And then Mosen Zanu, we don't know the PFS, but the CR rate is 81%. All of these are median follow-up is pretty short. What about second-line follicular lymphoma? The Epcar R-squared and the TAFA R-squared are both in the NCCN guidelines. The Epcor has a higher CR rate, and the PFS has not been reached. It's estimated 86%. With TAFA R-squared, it's a little lower. But remember, TAFA, for Epcor, you have to be in an area where you have Epcor availability and the supportive care because of the CRS and the necessity for getting tocilizumab easily available, whereas the tafasitamab doesn't need any of those special things. So the key takeaways of bispecifics are being evaluated in frontline high tumor burden. They need longer follow-up. Infections, I think, are about 30% in real, so they need prophylaxis, and we have to really look out for them. Educate our patients. Epcor R-squared has been approved now for second line. The InMind study, the post ad hoc analysis also shows that it's active in second line, also in the NCCN guidelines. And for third line, there's no new safety signals with Xano-Oben. And this is, I'd like to acknowledge, of course, the investigators who shared their slides and my research team who helped me with getting some of the data together. So that is my last slide, and I will stop sharing, and I'm happy to take any questions you might have. And sorry if it was like a monotone for an hour.
Thank you so much, Dr. Ranjana Advani. You updated us with large amount of data. It looks that everything is going to become chemo-free. Thank you. Questions for Dr. Ranjana Advani? It's pretty late in the day over this side.
Yeah, it's the night. It's about 9:30 at night for you all.
Almost, yes. Okay, nothing in the chat box and no questions from the people here? Yeah, Gurpreet.
I think Dr. Gurpreet has one.
Good evening, ma'am. Thank you for a wonderful lecture. It's great to hear you again. Ma'am, I'm a pathologist. What I want to know is that every year the WHO is adding on new entities, DLBCLs are ever evolving. So do we see a future where, it's not so fast, it's so rapid, and as pathologists, we're just finding it difficult to kind of catch pace with, all the newer entities that are coming up. So my question is, ma'am, what is the basis and how much of an evolution in this do we see in the near future as per your experience? How much more change do we anticipate?
Well, I was in just last month, I was at the advancement meeting, which is, as you know, right now there are two classifications, right? You have the WHO and you have the ICC classification, the International Consensus Committee. So both the groups met in Chicago last month, trying to see, can we harmonize it so that there's one classification? What we do know is just a simple cell of origin by immunohistochemistry doesn't cut it. We know that non-germinal center does worse than germinal center, but there were about 8 or 10 trials with over 10,000 patients adding agents which work much better in the non-germinal center when you add it to frontline therapy, selecting for non-germinal center patients, the trials were negative trials. And when you look into molecular subsets, we realize that not all germinal centers are very good. There are subsets within the germinal center type, such as the dark zone signature, which do worse. And then within the non-germinal center, not all non-germinal centers are bad. There are the clusters, the MC and the M5, which MC3 and cluster 3 and 5, which are enriched for the NF-kappa B pathway or for the MYD88 mutation. Those tend to do worse. So I do think that and there are data now looking at responses based on those molecular subtypes. So I do think, at the broad application scale, it's still not ready for prime time because these are very difficult tests and expensive tests to do molecular classifications, but they will get simple because the goal is to, convert them to immunohistochemistry based algorithms, which then people can follow. But it's not in the next 1 to 2 years, but I do think in the next 5 years, therapy will be tailored for large cell lymphoma based on molecular subsets, which there will be a cheaper and more efficient way to identify it. I don't know if that answers your question or not.
Thank you, ma'am.
Thank you, Dr. Gurpreet. Any other questions? Is the ctDNA becoming the standard of care in clinical practice in US?
So the only place where it's approved and you do something about it is in mantle cell. We are once at the end of treatment we follow them with clonoSEQ also to see if you can think. And then the other thing is if you say have DLBCL and at the end of therapy you have an indeterminate PET scan, so you have one spot of one little area which you can't biopsy, but a Dovil 4, Dovil 5, one little area. Is it really disease? Is it really, or is it a false positive PET? You can order a face-seq test. You can order it through Natera now. And if that's negative, you can be assured. But short of that, it's not being used routinely in clinical practice because it's expensive and not available everywhere. So we have it because we're an academic center, but it's being done in the research setting. And so far, it's still not in standard of care, unless on a trial.
And do you see CAR-T moving in the first line in some very high-risk lymphomas?
So the trial's ongoing for very high-risk large cell lymphoma. I think it's Zuma 25 or something like that is the number, where they're looking at comparing CAR-T versus standard of care therapy like EPOC, and in very high risk. And it's to be seen. I think the competition is the bispecifics, which there are now 3 randomized trials which have looked at adding bispecific to chemo. It's a lot easier to give a bispecific than to give a CAR-T. And I think with all these therapies, the longer term effects of the depth of immunosuppression, we have to really be careful about because these patients do get infections. Now, right now we use it in the relapse setting. I can't tell you how many patients I'm prescribing replacement IVIG because they're getting infections after CAR-T. And honestly, even some after bispecific where the IgG level is like, quantitative immunoglobulin IgG is like 200, 250, and they're getting infections. If they don't get infections, I don't treat it. But it seems like, I almost never used to prescribe IVIG, I mean, unless it was a CLL patient with hypogammaglobulinemia. But now it's like, it's becoming as if it's noticeable how many prescriptions we're writing.
Yeah. Right then, Dr. Ranjana, thank you very much. This was
You are welcome.
Really updated. So much of material has come up. My God, thank you. Thank you.
Take care.
Bye-bye.
Bye. Bye-bye.